So we have just enough time. Nishikant Borse could not make it to come to this meet, but I have requested Sangeet to present a few things regarding submacular hemorrhage. And if time permits, I'll show my video at the end, otherwise it's yours. And Sangeet, I've requested him to show a technique that he has innovated for TPA injection inside the OT, how to manufacture that needle and syringe.
Can play the video. It's just a video. You can play it. Yeah, you can have some audio with there's audio also. Video with the audio. No?
66-year male, who had undergone multiple intravitreal injections of Avastin, presented with persistent submacular hemorrhage. 27-gauge vitrectomy was done without base excision. Internal limiting membrane was peeled using ICG dye. A 40-gauge microcannula was used to inject TPA into subretinal space. TPA is used in the concentration of 12.5 micrograms in 0.1 ml solution. TPA is injected till it covers whole of the submacular hemorrhage and reaches beyond the temporal arcades. Fluid-air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. Visual acuity improved to 6 by 36 after 2 weeks and to 6 by 24 after 4 weeks of surgery. The most common complication seen with this procedure is a macular blowout resulting in a macular hole. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 ml syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. A 42-year female presented with macroaneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. PVD was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. A 40-gauge microcannula connected to the subretinal injector was used to inject TPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid-air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6 by 12 at 4 weeks post-op. These are a few more cases of submacular hemorrhage treated with the same technique. Let's see if the subretinal injection of TPA is a viable option for large submacular hemorrhage or a retinectomy with drainage is needed. 85-year male, presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCV. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment and subretinal hemorrhage in other eye too about 3 months ago. We plan to do vitrectomy with subretinal injection of TPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM peeling was done. TPA in the dose of 25 micrograms in 0.1 ml was injected subretinal using a 41-gauge micro cannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. 20% SF6 gas was used as tamponade. Patient was advised prone positioning postoperatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.